Did you know that nicotine affects your mental health as well as your physical health, and not in a good way? Learn why you should believe that you can stop smoking or chewing tobacco even if you've tried and failed several times before. Yes, you can be successful. Find out how next on Speak Your Mind. Welcome to Speak Your Mind. I'm Dr. Carolyn Phelps, licensed psychologist with the Human Development Center. We're talking about addictions again tonight, and when we usually think about addictions, we think alcohol, we think drugs, and we think, you know, people who are addicted to those, they really need help. But we don't always think that way about people who are addicted to nicotine, people who smoke or chew and can't seem to stop. We think things like, you know, you really should stop, as if the people using tobacco have never had that thought before, and as if it's, well, that easy, which those who have tried and failed know it's far from easy. Tonight, we're going to get our minds right about nicotine addiction, and you can help us by calling in your questions. Locally, dial 218-788-2844 or call toll-free at 1-877-307-8762. We'll be answering your questions throughout tonight's show. Joining me now is Dr. Michael Burke, an assistant professor of medicine at the Mayo College of Medicine and the director of the Mayo Clinic's Nicotine Dependence Center. Thanks so much for making that long drive up from Rochester. We really appreciate your coming here tonight. And first of all, tell us a little bit about maybe what are some facts that people ought to know about nicotine that maybe they don't know?
Okay, a couple of things. Nicotine is certainly the drug that people become addicted to. But nicotine by itself is relatively benign other than the addiction. It's sort of along the lines of caffeine. However, tobacco kills more people than any other product. 60% of the people who use it, as the manufacturer intends it to be used, die from it. And so we look at the cigarette and chew tobacco as drug delivery devices that cause a lot of mortality and morbidity. So
is the terms that we really should be talking about is tobacco addiction, not nicotine dependence so much then?
Well, tobacco addiction and in the diagnostic manual that has all the addictions, tobacco use disorder is the current terminology that's used.
And so how is it that tobacco is sort of more the addictive piece of that rather than the nicotine itself?
Well, the nicotine does cause the addiction, but when a person lights a cigarette, the combustion creates thousands of compounds, 30 of which are Class A carcinogens. Some things like carbon monoxide make it so that the cardiovascular system has to work harder. Other compounds affect the vascular system so that the veins and arteries don't dilate the way that they're supposed to. So all of the things that come around the nicotine as a person smokes a cigarette, that's what causes the harm. But the nicotine being delivered by a cigarette is very addicting.
And its effect on the body, because I know, you know, some people say like, oh, I smoke a cigarette and it calms me down, and others say like, oh, I gotta wake up, I gotta go out and have a cigarette. And so is it more of a stimulant to the body or more of a depressant to the body and a calming agent?
Yeah, any drug that addicts affects a particular part of the brain that produces a chemical dopamine, which is a feel-good chemical. As somebody, when they're young, they begin smoking. We're finding we can see children addicted, smoking as few as 2 cigarettes a week. We can identify them through a questionnaire, the Hooked on Nicotine checklist, that has a number of different withdrawal symptoms. Or, for example, a person has craving when they can't smoke. Nicotine stimulates dopamine, but then shortly afterwards, the body begins to rely on the nicotine in order to stimulate the dopamine. So a person is deprived of just feeling good. So when they smoke, their natural feel-good chemicals are restored.
And so then the people who use it as, who like feel like, oh, I'm really stressed out, I need to go have a cigarette right now, and smoke more when they're under more stress, how is nicotine affecting them in that way then? Is that an association where, you know, I think some of the addictiveness to smoking also seems to be in what we associate the smoking with. If I think that it's going to be a stress reliever and I've got a lot of stress in my life, I come to associate that more and more. And tell me sort of how far off base I am on that.
You're actually right on target, because another aspect to the addiction, in addition to the reward chemical, that chemical is very reinforcing. So, for example, a mouse sees cheese, right? Gets a little dopamine, says, I'm going to get something good, goes and gets the cheese. And what the brain is designed to do is hardwire that situation so that when the mouse sees that situation, it knows it goes here, gets the cheese, gets the reward. There's an association. The cigarette delivers nicotine to the brain more quickly than a hypodermic needle can. So a person gets very quickly relief from these unpleasant feelings and pleasure. So it gets connected to every time a person takes a drag, it gets connected very powerfully, hardwired to that situation. Now, the cigarette itself doesn't relieve stress. It is more of a stimulant. But usually when a person something stressful happens, they'll step away from the situation, light a cigarette, take a couple deep breaths, and think about the situation. Now, stepping away, a couple of deep breaths, thinking about a situation, all do relieve stress. But their brain's been tricked to think it was that burst of dopamine that's brought about that stress relief, when actually they probably have pretty good coping skills for stress, but the nicotine is sort of claiming that.
I love that concept that you just talked about, that they sort of unwittingly practicing good stress management techniques and good deep breathing techniques by inhaling, which is then, of course, in some ways also counteracted, at least physiologically, by maybe long-term over time, about nicotine or tobacco, inhaling tobacco and smoking, you know, obviously reducing lung functioning. When, you know, it seems to me also that there's also a social component. We know that there's a social component to at least cigarette use and smoking, where people will often, you know, either take a break, you know, they're taking their cigarette breaks with other people. That becomes sort of an enjoyable experience as well, that's connected. Or if they're out at night at a restaurant, or, you know, wherever they're smoking aloud, or if they're out socializing and smoking in that context, that social connection also kind of pings on the reward system as well.
That's right, and it pings on that reward system so that all the enjoyment of socializing or laughter or the relief you get from stepping away from a situation, all of that gets associated with the nicotine. And in fact, it's an imposter. It doesn't do those things, but it's actually taken away a person's experience of that without the nicotine. And a big part of the recovery is giving enough time so that those usual rewards in life, good friends, a good food, a beautiful sunrise, that those things that dopamine is designed to respond to, by stopping to deliver the drug that your brain's begun relying on for that burst and for that ping, as you say, over time, those real enjoyments can return.
Now, my producer had asked the question, well, why do people smoke even though everybody knows at this point in time what the potential negative physical health outcomes are from smoking? And how do you answer that question?
Yeah. Many people when they're young, they try cigarettes. Not everybody proceeds to continued smoking. We think for some people very early on, and probably a lot due to genetics, the ping that they get from cigarettes, the reward, is more intense. And so when they don't have the cigarette, they'll feel withdrawal symptoms, irritation, frustration, depression. And then when they're in a situation where they would usually smoke, like with a friend, it's ping, now have one. And those two deprivations and needs can call very loudly to a person. And so it's easier to say, well, I'll quit later, or I'll quit another time, or it's not really that bad, is it? And so when a person doesn't feel capable, maybe doesn't have the they don't feel that they can effectively leave the cigarette or leave the chewed tobacco, just almost automatically they'll discount some of the health messages.
And I think it doesn't help at all that when people either first take a drag on a cigarette or when they first start chewing, it's not as if they have, most people don't have this sort of negative, horrible physical reaction right away that continues every time, where they feel sicker and sicker and sicker. I think if they did, it's many of these health consequences are so far down the line that you always feel like you have another day then.
Without a doubt, yeah. And there are many people that use drugs like alcohol or other drugs that they use them recreationally and they don't experience problems, and they're not addicted. They can use the drug socially. Some people can use tobacco that way, but very few. Probably 80% of the people who use tobacco become addicted to it, compared to maybe 15% of the people who use alcohol.
That's amazing. What accounts for that difference? Because you just said, and so I think this bears repeating, 80% of the people who use tobacco become addicted, as opposed to 15% of the people who use alcohol. And so what do we know accounts for that difference then?
It's a very potent, addicting drug. It stimulates dopamine very rapidly, and those associations, if a person smokes a cigarette, they'll maybe take 10 drags, so they have 10 connections with having the coffee, getting in the car, something stressful. And so it's those reminders happen quickly and happen through the day. But as you were saying earlier, other drugs, when people do develop problems, they look to bottom out. And unfortunately with tobacco, for many people, the bottoming out is illness and death later on in life.
Mm-hmm. Mm-hmm. And let's talk a little bit about because this is a show about mental health and mental illness, and so let's talk a little bit about the relation between tobacco use and mental illness.
Yeah. We know how to address what in my field we call the tobacco epidemic, how to, from a public health perspective, reduce the prevalence of tobacco, increasing the price, making it so that people can't smoke indoors, good education, treatment, all work. And we've made some tremendous progress over the past 40 years, from smoking coming down from 40 to 50% of the population to about 17% here in Minnesota. But that progress has not occurred for people who have mental health problems or other addictions. And this is a real tragedy. Today, 44 out of every 100 cigarettes are smoked by people with a mental health problem. And those people are dying 10 years earlier than other people, mostly due to the smoking.
Not to the mental illness per se, but to the effect of the smoking.
Yes, it's an awful thing to have schizophrenia or bipolar disorder. It can be managed, but it's a difficult thing. But to have bipolar disorder and lung cancer or emphysema is more awful. And that's what's, just for example, with alcoholism, a study was done out of the Mayo Clinic alcohol rehab, looking at people who'd come through the program over the course of 20 years and comparing the people who'd come through the program with a group of people who hadn't come through the program, and looked at death rates. And certainly people who'd come through an addiction program are more likely to have died than people who hadn't. But 51% of them died from their tobacco use. So they'd been in drug treatment. The drug that was going to kill them, they weren't treated for. And more than half of them who died because of it.
And why do we think that we're not making these same kind of inroads in terms of addressing tobacco addiction with people who have a mental illness, as opposed to the segment of the population that doesn't have a mental illness or other addiction?
Yeah, and that's why I was really glad they invited me here, because it's something that we need to make inroads. It's a tragedy that's happening and is not getting the attention that it needs. Partly because people with mental health problems or other addiction problems become more addicted because of a number of reasons, so it's harder for them to quit, so the treatment needs to be more intense, more aggressive even. And because, unfortunately, I think people, and you know, my training is as a psychologist, and I think we've neglected it. We think, oh, well, don't take the smoking from them. They have too many other problems. And I look at that as a stigma. This person doesn't deserve the treatment for the drug that's going to kill them because of the mental health or other addiction problem.
I think that is really, to me, just kind of a little mind-blowing, that notion, because I know I've been guilty of that notion of, well, we have so many other things that we want to help you with and work on, that we don't need to start with your stopping smoking, or you're giving up your tobacco, and really kind of, and sometimes colluding with the person that this is a lesser problem to deal with, and not doing adequate education, because I think, frankly, I don't know that we're educated the way that we ought to be on this. I know that there have been some treatment programs as well that use cigarettes to incentivize people taking their medication. Talk a little bit about that.
Yeah, or to take a break. It can be almost built into the culture. And there are a couple of model programs where they've taken mental health consumers, people with mental health problems, who have gone through a program and have stopped smoking, and put them through a training program so that they can go back into the mental health facilities and train the providers and say, we can do this, and they can do this. You know, many people with schizophrenia, bipolar disorder, major depression do quit. And what we find, and it's a little counterintuitive, is that if you look at a person's anxiety, depression, stress level, quality of life before they stop smoking, and 2 weeks afterwards, all of those measures improve. People are less depressed, less anxious, they have less stress, as you might measure physiologically, and their quality of life is better. And they're less likely to relapse to their drug of choice if they're being treated for alcoholism, for example.
Talk a little bit about that, about how stopping smoking or stopping your use of tobacco if you're in treatment for another drug or alcohol problem, how this sort of, well, if we're quitting, let's quit. Not let's cherry pick among the things that you're addicted to. Let's take all of those things that you're addicted to. How does the stopping smoking enhance the likelihood of successful drug and alcohol treatment?
Yeah, there was a time, you're not old enough to remember, but I do.
Well, that was
when
kind.
we had
We'll be having him back on the show, won't we? There, he's back on next year.
When with drug treatment, long-term drug treatment, they would give the people who are coming through treatment drinking privileges once they had achieved a certain, and what happened is that relapse occurred. We think that there may come a time that we'll look back at what we're doing with tobacco and say, boy, the same as we do with alcohol and drug treatment, that doesn't make sense. That there may come a time when we look at this and say this doesn't make sense. But it's hard to treat, and it takes a combination of medication and intensive counseling and a commitment by the organization. As you said, the organizations begin to rely on it for breaks, for rewards.
This is, you mentioned that the treatment, and we, gosh, we need to start talking quickly because we're getting short on time, which I can't believe that's a true statement. But you said combination of medication and then behavioral or cognitive behavioral type interventions. And a woman from Two Harbors called in to say, why is it that Chantix can't be provided to people diagnosed with depression? So I guess the first part of the question, the first question I would ask you is she correct that Chantix cannot be provided to people who are being treated for depression? And I think, I would guess she means I'm maybe not diagnosed with depression, but maybe on other medication for depression.
Yeah. Well, Chantix is one of 7 different medications that can be used to treat tobacco dependence. Many of them are replacement nicotine products. The good news on Chantix, and this is a new study that just came out 2-3 months ago, large study, 8,000 people recruited to it, and they actually recruited people with mental health problems because they wanted to see, does Chantix really cause an increase in mental health problems? And the answer is no. And the FDA wanted this study in order to take the warnings off of the label. Chantix does, 30% of people cause nausea. Some people it causes vivid dreams. Some folks love it. It's like a free trip to Disney. Other folks,
not so much.
Not so much, you know. But in terms of the mental health problems, it's actually a relatively safe drug, and it doesn't interact with any other medications. So we're thinking that concern is going to fade. Now, what I'd recommend to the caller is talk with your provider about it and refer him to or her to the EAGLE study, which is the new study that really is reassuring regarding the mental health problems.
And I think, though, what you also said is that it's one of 7, so that there are 6 other medications. It's not a one and only out there. What are some, there are a lot of people who just don't have much hope in their ability, they're discouraged about their ability to quit, and what would you say to and so then they stop even trying or wanting to try because they don't feel like, well, what's the point of trying? I'm not going to be successful. And what would you say to those people?
Yeah, and that is really a shame, right? And certainly, each time a person tries to quit, the likelihood that the next attempt will work for good increases. Each time a person tries, they learn something. And I'd say, learn something from the past attempt and use that to increase the intensity of the next attempt. Things like medication, combination nicotine replacement therapy, behavioral counseling, working with a tobacco treatment specialist or calling a quit line. All of those things improve success. We treat tobacco dependence better than we do other addictions in terms of outcomes, as well as we do diabetes. So I'd say talk to your healthcare provider and give it another try. It's important, and once you stop, you're going to be so happy.
And so there is reason for them to feel hopeful then.
Without a doubt.
Well, we have come to the end of another show. I cannot believe that was over so quickly. I wish we sort of had a part 1 and a part 2 on this. So what will we do? Well, we'll just have them back on another season. That's what we'll do. So this is what Dr. Burke said. Number 1, there is reason for you to feel hopeful. Number 2, he didn't say this, but he kind of said this, and that is that what thing in life do we do perfectly the first time out? That'd be the big fat nothing, right? So why do we expect that people are going to be successful on their first time out? Maybe you are, maybe you're not, but if you're not, that's not a reason to feel hopeless. It's just a reason to try again. The third thing he said, this might be my favorite thing that he said, is that assuming people with a mental illness cannot quit smoking and don't deserve to be given an opportunity to quit smoking, that's stigmatizing. This show is about decreasing all stigma that surrounds mental illness. So I think we all need to start being a part of that solution, especially you providers out there. Thanks so much for joining the discussion tonight. And don't forget to visit us on the web at speakyourmindonline.org, where you can find a schedule of our topics and resource links. Join us next week when we'll be talking about medications, mental illness, and what's new in psychiatry. I'm Dr. Carolyn Phelps. Thanks for watching, and good night.